I'm Shivesh. I'm one of the intensive care specialists here in Adelaide, working at Flinders Medical Center and DDU examiner. And I think the topic which I was going to talk about was role of echo in respiratory failure. Now, yeah, amongst you all, are you going for DDU exam over the next 1 or 2 years?
Hi, Shivesh. My name's
Jiten?
Jatane. Yeah, I am hoping to sit hopefully in the next I don't know, 6 to 12 months.
Okay, fantastic. Yeah. Look, so yeah, I'm not sure who else is going to join, but we might just slowly start. So, look, echo in respiratory failure. It's unlikely that you would get a question like, "What's the role of echo in respiratory failure?" It's most likely going to be a scenario, clinical scenario, and I thought it's one of the favorites, and it has come in the past using several clinical scenarios. And look, one of the previous question was, let me share my screen. Can you see this word file and a question on it?
Yep.
Yep.
Yeah, fantastic. So look, I must say I don't have a PowerPoint slide at all. So it's gonna be brainstorming, discussing aspects rather than a didactic sort of a teaching. So this was the question which came before. So here is a 35-year-old patient, day 3 in ICU, background of COPD, intubated for respiratory failure from pneumonia, and he has deranged LFTs and acute kidney injury. How might echo help you managing this patient? So I would probably start by just brainstorming as to what would be a good sort of starting opening statement here. Any thoughts?
I mean, could you say you could use echo to look for potential cardiac cause of respiratory failure and also cardiac sort of consequences as a result of pneumonia or something like that?
Fantastic. Yeah. So I guess what you're getting to is looking at the cause of respiratory failure, and as you're saying, it might be cardiac, or it might be, or the consequences or the complications of whatever is going on. So the echo can help you with not only ascertaining the diagnosis, confirming the diagnosis, its complications, and then of course it can inform the treatment going forward. And one of the other things which just takes just a sentence to talk about is what's the echo's role? I mean, you have got the CT and other investigation modalities, but the echo is going to be cheap, bedside, very quick, less invasive, don't have to move a sick patient. And this is one modality where you can examine several systems in one go. So it just takes one sentence, but there may be points on identifying what's the role, what's the advantage of going for echo. Yeah, so like it. Well, that's a nice intro. Any other thoughts or comments?
Can I ask a quick question? When
Mm-hmm.
it's phrased like this, does it mean just echocardiography, or is it referring to ultrasound in general?
Ultrasound in general. So I guess once you've got this intro, the next is just talking about how it can help with those diagnoses and the complications and the guiding the management. Obviously, when you are starting with a respiratory failure, you would probably start off with a sequential assessment starting from the lung ultrasound, and obviously it's sequential assessment guided by incremental findings. So obviously the next system I'm pretty sure you all would go for is cardiac, but to be fully informed, you would probably do an abdominal ultrasound as well as the leg vein ultrasound to complete the respiratory sort of failure drill. So I guess if you start off with the lung ultrasound as the first aspect of your examination, any thoughts on how you would, what sort of probes would you use and the machine settings?
So I guess a curvilinear probe,
Yeah.
traditionally set to either lung or abdominal presets. starting with initial, I guess, preset frequency and then adjusting based on image quality and penetrance.
Yeah.
With, I guess, I don't know how much detail you would go in, but I guess like orientating the probe quarterly and translating it slowly inferiorly on the anterior, lateral, and posterior aspects.
Yeah, so look, that's the challenge of this, because I'm sort of discussing this question, but I'm gonna pitch it to I'm going to veer off from the answer structure to various aspects which are important, because I'm not sure about the audience as to what level they are, and hence we might discuss various aspects. So I guess, well, as you said, for the answer, you wouldn't dive into much details about what probe or settings would you use. I guess it's worthwhile to say that start with the lung ultrasound. I would examine, I guess there are, if you want to examine 3 sites on one side and then on the other side, so that's 6 in total. Anterior axillary, mid-clavicular, mid-axillary, and posterior axillary is my favorites. But again, you can divide them further into upper half, lower half, and sort of make it more comprehensive. Why do we use lung presets? What's there in the lung preset?
I think it's the harmonics off. Is it automatically when you use lung preset?
Yeah. Well, so why do we need to switch off the harmonics?
Because you want to preserve all the artifacts to enhance your A-line, B-lines.
Yeah, fantastic. Yeah, so you have to switch off the harmonics because traditionally it goes for the second harmonic, isn't it, to minimize all the artifacts. So you want to switch off harmonics. It also does the compound imaging and reduces the grayscale a bit. So it makes it more granular. I guess, especially if you're looking at lung sliding, it makes a big difference. So make sure you've got the presets and the probes, the position of the patient, location where I'm going to examine. In terms of how would we go about structuring this now further? So you've got this patient, you're starting off with this clinical detail, and you're going to use lung ultrasound first to examine. So how would you go? Any thoughts on structure of the answer?
I think, can I use something like generic, right? It's going to be part of my multimodal assessment and, like a dynamic assessment as well with the intervention, and then use it to, I think, complement other ultrasound to like VAXs and other things. I just don't know how to put it all together in sentence.
Yeah, I think what you are talking is somewhat similar to what we talked about earlier, that it's not just lung, it's going to spread out to abdominal, VEXA scan and all in the intro. So in the lungs, I guess in the lung ultrasound, what we are looking at is what sort of artifacts are really helpful? What are you looking for in the lung ultrasound?
So I guess you're looking for B lines, you're looking for the presence of lung sliding. And then going slightly beyond just generic, I guess you're looking for evidence of hepatization, consolidation, or air bronchograms. And finally, you'll be looking for evidence of effusion or atelectasis. Would I guess be my structure or approach?
Yes. So that's great. Now, sorry guys, my whiteboard didn't come up, and it looks like on the Word, if I try to write something up, it's trying to type that up in a weird sort of language. So I guess, we'll just talk about it. So, okay, great. So lung sliding, you're looking at the bright hyperechoic line just between the two rib shadows, what they call as the bat wing sign. And that hyperechoic line that you're seeing is essentially your parietal pleura, isn't it? And so there's a marked difference in the echo impedance, tissue impedance before and after that line. So I guess it causes a lot of reflection back. So it's very bright. And it's normally you would like to see a bit of lung sliding with breathing. And with to be more accurate, you can always use a linear probe, which obviously because of the high frequency get a bit more definition there, and use a M mode to have a look at the lung sliding, which looks like the conventional seashore sign with the sort of horizontal lines at the top and the more granular appearance at the bottom. Now, I'm assuming you all have been familiar with lung ultrasound before. Otherwise, I'll have to. I can bring up the PowerPoint and show you all the lung sliding and the pathologies. I'm open to that. If well, it's a small group, so I'm happy for you guys to guide the structure.
Do we have time for that? If we have time, I think I'll appreciate it.
Okay, yeah, no, fantastic. Look, would it be okay if I bring up all the images at the end? I'll make sure there's time for that. Yeah.
Thanks.
No, good. So, yeah, lung sliding. Now, normally we would like to see lung sliding, but if there is no lung sliding, you're not seeing much lung sliding. What does that mean?
So it doesn't definitively mean that there's a pneumothorax. So there's a few different reasons. It can be
good
because of the presence of atelectasis, but it can also be increase the likelihood of a pneumothorax, which ideally you'd want to confirm with one of a couple of tests, either with the presence of lung point at some point in time, as you further examine the lung, or alternatively, if you see lung pulse, that can at least exclude a pneumothorax usually safely.
Yeah. So yeah, unfortunately, it's not a specific sign, absence of lung sliding. So if you don't see a lung slide, and I've seen this in some trainees thinking that, oh, there's a pneumothorax, but some of these studies have talked about positive predictive value in respiratory failure patients down to 30% for pneumothorax. So it's by itself, it's not of much use. And if you find that, I guess you want to move your probe laterally to see if you're seeing lung point. And what is lung point is basically you can actually see the lung coming into the sector and then going out with inspiration. If that happens, that really increases its positive predictive value for pneumothorax. So if you can see that, then that's really helpful. I guess there are a couple of things that you might find as well, which might rule out the probability of pneumothorax is signs such as a B line or a lung pulse. So what are the other, why is its positive predictive value is so poor? I guess it can be found, lack of lung sliding can be found in inflammation, fibrosis, ARDS, collapsed lung, low tidal volume ventilation, such as during ECMO. So there are so many causes of lack of lung sliding. So it's not just pneumothorax. But I guess one of the helpful signs is lung pulse sign. So if you have got situations such as an atelectasis or a poorly ventilated lung, then I guess if you put an M mode on, it's more visible in M mode. If you put an M mode on the lung parenchyma, and you can actually see the cardiac oscillations on it, and that sort of confirms that there is no pneumothorax over there. And B-line is another artifact that is very useful. So it's a good segue into B-line. What are B-lines?
So B-lines are, somebody else can talk, by the way. I feel like I'm talking a lot.
Others can chip in if they want. Yeah.
They are reverberation artifact that extends from the pleura, usually to the entire depth of the image, and usually moves with pleural movement. Is that right?
Yeah. So great. So a reverberation artifact appears as a linear echogenicity extending to the lower half of the sector. So now, how deep should be the sector? I guess does it matter when the definition has that it should move to the end of the sector, but how deep should the sector be?
Yeah, I'm not sure about that one.
Yeah, it's important because there are other artifacts. They call it Z line for some reason. It's quite horrifying to see some of the articles out there. They have got lines A, B, C, D, E, F, all the way to this Z. But thankfully, for DDU and day-to-day purpose, all you need to know is A line, B line, C line, and Z line. That's enough. So Z line are similar sort of linear echogenicities, which sort of arise from the pleura, but the clinical significance is not there at all. But they don't extend beyond a few centimeters and do not extend to the deep part of the sector. So if you're doing lung scan, you probably have to be looking at around 12 to 16, sort of 14 centimeter depth of the sector. So all these definitions, they are assuming that you're using that sort of deep sector, 12 to 14 sort of a range. So good. They are linear echogenicities, arise from the pleura. They are reverberation artifact, and they move with the pleura, with the breathing. And can there be a B line and A line at the same time?
I mean, usually B lines sort of obliterate A lines. Is that?
Yes.
Yeah.
Yes. Yeah. And I guess it makes sense because now the reason why we are having B lines is because the just below the pleura, there is thickening of the septum, and the thickening might be because of the fluid most commonly, but it might be fibrosis, inflammation, inflammatory infiltrate, whatever. So the tissue underneath the pleura is not healthy, not aerated. It's getting edematous. So for the A line to occur, there should be aerated lung below the pleura or air, basically. And that's how the A line generates because of the marked tissue impedance difference between the both above and below the pleura. So if you're getting B lines and B lines are significant enough, that means the tissue is becoming more and more solidified or edematous, and in which case you won't see much A lines. Hopefully that makes sense. So it's there in the definition as well. So it obliterates the A lines. So I guess as we did, B lines occur when there is thickening of those interalveolar septi, which might be not just edema. We think that most commonly it's edema, pulmonary edema, or cardiogenic pulmonary edema, but it could be other things as well, such as fibrosis. So you have to bear that in mind. But the dynamic changes in the B lines, the more the B lines, the more is the extravascular lung water. And that has been shown quite strongly in literature time and again. To be significant, you are looking at 3 or more B lines in a sector. And as there is more and more extravascular lung water, you see complete homogeneity of the sector, diffuse whiteout. And then the extreme is hepatization of the lung, which pretty much looks like a liver on the ultrasound then. We've got some images at the end, so we can see that. So that's the B line. So we have gone through A line, B line, lung sliding, and that's pretty good, and we can discuss how things would change. So now next thing, so this is how I will do in this question, that I would talk about, well, echo is very handy because of these advantages, just one or couple of sentences. It can help with the diagnosis, its complications, and then guide management. Then it would be a sequential assessment starting from the lung, but going to cardiovascular, pulmonary, abdominal, and likely leg veins. Depends on what the clinical context is. And this clinical context, look, based on this clinical context, then obviously it's a DDU critical care exam. So there would be some content knowledge expected. In this sort of clinical history, what sort of differential diagnosis we would be thinking of? So this could be brainstorming time. You guys can pitch in with differentials. So I guess couple of things are already given there. Pneumonia. So this guy could be having worsening pneumonia. What else?
So kind of like Hay mentioned earlier, I guess you could divide it into both primary respiratory causes and then secondary cardiac complications or cardiac causes. So you mentioned pneumonia. He could obviously have things like pleural effusions or atelectasis. From a cardiac point of view, he's got a history of COPD. So you'd be worried about evidence of right heart failure in this gentleman, which can obviously come in a variety of classifications. You'd be worried about congestive hepatopathy from the right heart failure with his deranged LFTs, as well as kidney injury. But I guess we can get to that when we get to abdominal. He could have a primary cardiac cause. His left heart could be failed, and he could have an element of APO, which might be seen with B lines on his echo. As part of the right heart failure component, you'd obviously want to investigate his pulmonary pressures. Acute RV overload, like in the presence of a different differential, like a PE, would probably be worth investigating and excluding. I guess would be the primary cardiac things I would think about for respiratory failure.
Yes. Okay.
And then I guess
any other thoughts? All right, let me.
I guess I would divide it into, when thinking about cardiac specific, systolic and diastolic function along with valvular function.
Yeah. All right, great. So we have got primary pulmonary problems, we have got left-sided heart problems, and right-sided heart problems, which are most likely going to be the consequence or a complication of what's going on in the lungs, or it could be primary problems such as pulmonary vascular problems or PE. So I guess that's very good, and obviously the question has information for a reason, and probably that's why they have put deranged LFT and acute kidney injury. And you could mention this early on that you would be worried about respiratory failure and right heart failure as a consequence. So in terms of pulmonary problems, we talked about pneumonia. What I might do, a good structure for it would be, I wish I had the whiteboard on, but maybe I will try this, draw with a touch, and hopefully it stops printing stuff. Let's see, is it doing anything? Okay. All right, so just making a table. And you can write the lung sliding and with pleural line. You can write about what happens with the A line and what happens with the B line and what are the other findings. And then you've got pneumonia. So some of the pulmonary causes that you would like to look at is pneumonia. Then you've got COPD with exacerbation. You mentioned atelectasis, which is quite relevant. I mean, in ICU, you guys might have seen the endotracheal tube goes down the right main bronchus all the time, and then you've got one side collapsed, or atelectasis because of mucus plugging. Complications of pneumonia. You mentioned effusion, and we are pretty much looking at complicated effusion, empyema. What else? I'm not sure whether we discussed this. Now, this patient is at risk of developing lung injury. I'll just write ARDS. Anything else? You mentioned PE. So these are some of the pulmonary pathologies that you can easily assess with the lung ultrasound. And it's nice to put it like this because then it saves you time, and you can write about what happens to the lung sliding, A lines, B lines, and what are the other findings. So this is one of the structures I thought might be a bit time efficient. Obviously, it would change with what sort of questions you are dealing with. But if it's a respiratory failure, lung ultrasound question, then there would be bulk of marks on these pathologies being explored by lung ultrasound. So starting with pneumonia, we have already discussed the the lung sliding. What will happen to the lung sliding? Maybe absent or maybe present, but often it can be absent. if there is inflammation involving the pleura, especially. What will happen to the lung sliding on COPD? When you expect it to be present, unless you are dealing with the bullous emphysematous lung disease, and big bullae is a big problem in the lung ultrasound, because when you see that, you're not sure whether it is pneumothorax or whether it is a big bulla, and certainly you don't want to put a needle in the big bulla. Look, atelectasis, again, it's very easy, negative lung sliding. And what was E? E was effusion, pleural effusion. Obviously, lung sliding would be present over there. Sorry, that's negative. ARDS, it's usually negative, but I guess you can find positive as well. And PE is present. So you can see that lung sliding can be useful, but the absence of lung sliding is often not very helpful because of the various pathologies. Again, we have discussed about the A lines in pneumonia. What will happen with the A lines?
So I guess you often won't see them in densely consolidated lung because the area won't
Correct.
be aerated.
Yes, and important thing is the asymmetry. So obviously you're hoping that the pneumonia would involve hopefully just a lobe or a segmental part of the lung, and hence, especially if you're seeing A lines everywhere and then the A lines are absent in one zone, it's a stronger suggestive of pneumonia. COPD, you are likely to see the A lines. Again, during the atelectasis, what will happen in the atelectasis? Again, as we discussed before, there will be absence of A line. Pleural effusion, you won't get A line again because there's fluid on the other side of the parietal pleura, and then there's not much tissue impedance happening. ARDS again will be lost because of the same mechanism, and P will be obviously A lines present. And what will happen to the B lines? Again, we have discussed this in detail. You expect to find more than 3 lines in early pneumonia, but obviously especially if it is an viral interstitial pneumonia. But then if the classic pneumonia, obviously it rapidly progresses to consolidation range and hepatization of the lung. Obviously, COPD, B lines, you may find B lines, especially if there is fibrosis. Again, for in patients with atelectasis, you will find you can find the B lines depending upon the mechanism. And again, in the effusion, usually there is atelectasis of the underlying lung, so it's common to find B lines. Again, in ARDS, it's an interstitial syndrome, so you get a lot of B lines and just white out. And the PE, it's unlikely you will find a B line. It's sort of normal aerated lung parenchyma. It's mostly vascular problem. What are the other findings of in pneumonia that you expect to see?
Air bronchograms.
Yeah.
Dynamic bronchogram. Shred sign.
Yeah. So dynamic bronchogram. So I guess the in pneumonia, there's consolidation. There's likely to be fluid or pus in the small airways, and there's in contrast to atelectasis, if the air is still going in and out, then you might actually see dynamic air bronchograms where you can actually see a bit of movement inside the bronchi. If it's completely blocked off, then you can sometimes see fluid bronchograms instead of the air bronchograms, but they are more supportive of sort of atelectasis and complete blockade of the airways. And you said shred sign. So what is a shred sign?
So I guess shred sign is this characteristic carving out or like shredded appearance of the lung in the setting of really dense consolidation, where it'll appear like there are entire zones that are missing, or echo opaque. I'm not sure echolucent or echo opaque is the term.
Yeah, so it's pretty much a boundary between a normal lung and.
I think it looks like it was so bright.
Sorry. So it's basically a border between a normal aerated lung and the consolidated lung. So especially we see that in the segmental consolidation, not the entire lobe is involved. So you might see a patchy consolidation, and the borders are obviously irregular, not very well defined. That's where the term shredded comes from. So yeah, great. Air bronchograms, dynamic bronchograms, hepatization of the parenchyma, and shred sign. Any other features in other pathologies? Let's take effusion. There are so many signs in effusion. But essentially, you are looking at anechoic space, isn't it? And then you're looking for features of complications, so complicated effusion. So you're looking at adhesion. So you're looking at all that. So quad sign and the spine sign. These are all, I don't know what the utility of that is, to be honest. And there is sinusoidal sign, and it essentially tells you that there's a pleural effusion. Sinusoidal sign is basically the lung parenchyma coming closer to the chest wall and moving away with the breathing. So when you put an M mode, it just looks like a sinusoidal waveform. And quad sign is basically a quadrilateral form by the pleural surface and the parenchymal surface on the deeper aspect, and on the side, the limits of the effusion. And a spine sign is obviously you don't expect to see a spine doing lung ultrasound, but of course in large pleural effusion, because water is such a good medium of ultrasound, you start to see the spine coming into the picture. But what's useful is visualizing all these exudates, which sort of tells you that it might be a complicated effusion, and you might want to go in with the needle. So there are different fancy terms used for these exudates. There's punctate, plankton sign for these small punctate floating echogenicities. Then there is a jellyfish sign of this collapsed lung with fibrinous strands at the end. Are there any other signs that?
Swirl sign, swirl.
Yeah, swirl sign. So all these fancy terms have come. They're basically describing the same thing. In my clinical experience, obviously, you think that it would be an exudate, but when you put in the needle, you might find that it's still transudate. Or maybe we are good at picking them early. ARDS. Now, ARDS is a funny thing, because when you get patients with pulmonary respiratory failure, and it looks like they've got interstitial syndrome, the first question that comes into your mind is whether it is a pulmonary edema, like a acute lung injury, or is it a cardiac pulmonary edema? And any thoughts on how we could any ultrasound features which could differentiate pulmonary versus cardiac pulmonary edema?
No, I don't think it can be differentiated. I mean, unless you do an echo of the left heart and prove there's nothing wrong with the left heart, or prove that the pulmonary pressures are normal.
Yeah. So like echo, there's nothing hard and fast, but there are certain signs that you can that point towards cardiac etiology. So look, in patients with say they're developing lung injury, bilateral infiltrates, you put a probe on, and their pleural line is very irregular, as opposed to cardiac pulmonary edema, where the pleural line, when you look for lung sliding, is very linear. It's not irregular. And similar thing happens in early pneumonia, because we saw this in COVID pneumonitis, that there we had interstitial syndrome on echo, but their pleural line becomes very prominent, thicker, and irregular. And that points, and of course, the focality of the pulmonary process, whereas the diffuse sort of bilateral involvement of the cardiac. Obviously, there would be exceptions such as unilateral MR, etc. But there are some of the features that might point towards a cardiac versus non-cardiac. involvement. Great. So this is the pulmonary aspect. I guess the main crux is here. You would what's happening with his heart? That's the next question. And given the history, we all are worried about his right heart, isn't it? So how will we go about that? How will you assess the right heart?
It can be assessed globally, or you can look for regional function. The global parameters for assessment would be things like fraction area change. It should be more than 35% normal. And the regional systolic function assessment would be like a TAPC or a RVS prime assessment with tissue Doppler. We can also assess pulmonary artery pressures as a part of RV assessments. Again, RV size can also be assessed by measuring the various diameters, basal and longitudinal. Also, IVC can be assessed as a part of RV assessment to sort of assess RV pressures.
Yeah, I like how you mentioned both looking at RV, but looking at pulmonary hemodynamics as well, because this patient has got history of COPD, so he's most likely might have pulmonary hypertension from before, but now he's got pneumonia or maybe lung injury or ARDS, who knows? But his RV afterload would be significantly increased. And we might be dealing with a pre-capillary pulmonary hypertension and a high pulmonary vascular resistance. So essentially, when we are going to, obviously, before you put the probe on, you have got all this pre-test hypothesis in your brain that probably there's RV failure because of increased RV afterload. In severe acute lung injury, up to 60% of the cases might have RV dysfunction. So what are the features of high pulmonary vascular resistance? Because if I'm scoring this question, then I would be keenly looking for that.
So a short pulmonary acceleration time, less than 100 milliseconds.
Good. Yeah, fantastic. So look, less than 90 or 100 is significant, certainly correlates very well with the high pulmonary vascular resistance, more than 3 Wood units, and also the profile of RV profile. So I'm pretty sure most of you might have seen or heard of the flying W or mid systolic notching of the RVOT spectral Doppler profile, pulse wave profile. So that's one of the specific features as well for high pulmonary vascular resistance. So I would be looking for that. I'll be looking for dimensions and the function, all that you mentioned, fractional area change, TAPC, RVS prime, and TR. And you can use, obviously, TR for systolic PA pressure estimates. But if you've got a bit of PR, you can also assess the PA diastole pressure by measuring the end PR velocity. But for the TR, obviously, anything above 2.8 would make me interested. Be careful of, I mean, qualitative assessment of a TR jet is also quite important, isn't it? Tell me more about what echo features would support RV dysfunction or very high right-sided pressures.
I mean, there are some other 2D features like
great.
Flattening of the intraventricular septum during systole suggest pressure overload.
Yes.
Other Doppler features. I mean, maybe this is more chronic pulmonary hypertension, but you can get this PA RV uncoupling where TAPS is low, but your
TR is high.
Yeah, that's right. Yeah, TR is high. I forgot what the cutoff is. And one 2D feature I didn't mention was PA pulmonary trunk diameter, if you can measure that, and if that's dilated or bigger than the aortic root, suggest raised pulmonary pressures.
Yeah, and you can of course see other features such as coronary sinus dilatation, bowing of the interatrial septum as well towards LA. And all these features would support sort of elevated right-sided pressures. Obviously, RA dilatation, coronary sinus dilatation would point towards more chronic sort of RV problem, and then of course there can still be an acute on chronic sort of problem. But any other features of chronicity, especially for long-standing pulmonary hypertension, you're pretty much looking at fantastic RV trabeculations, RV hypertrophy. But you know what, RV hypertrophy, it's RV. The interesting thing about RV is that it can hypertrophy within 72 hours. So if the patient is coming late in the presentation, then it's not of much use. But more than 5 millimeters, you're looking at RV free wall. You will call it hypertrophic. But of course, increased trabeculations we usually see in very chronic sort of patients. All right. Moving on, obviously, by this time you will have an idea that the patient has increased RV afterload, there's RV dysfunction, but what are the consequences of that RV dysfunction? So let's talk about that. What is pulmonary vein to left atrium is hepatic vein to right atrium. So and obviously it would move on from right atrium to hepatic veins, and normally, as you guys know, that it's systolic predominant followed by diastole, and this AR you might not see in hepatic vein, not very clear, but essentially as the pressure goes up, you've got systolic blunting, and then of course the extreme is complete biphasic sort of waveform. When you get during systole, you have complete regurgitation of blood into the hepatic vein. You're looking at that. You're looking at IVC size, obviously, as a part, not only just as a part of estimating the RA pressures when you're trying to estimate the PA pressures, but yeah, if it's significant, you're expected to see a very fixed IVC, isn't it? More than 2.1 centimeters and not much variation. And moving on, these days you obviously have to talk a little bit about VEXIS, where you look at what are the consequences of this RV dysfunction. And one of the things you have to look at the portal vein, and again, the portal vein is again you should be seeing pretty monophasic continuous flow, but as the right-sided pressures increase, you might start to see more and more variation. So in the flow, and essentially you are looking at less than 30 is normal, 30 to 50 is mildly elevated, and more than 50. When you start to see a lot of variation in the pulmonary vein flow, then it suggests right-sided pressures and hepatic congestion mainly. And going down to the renal vein is the last thing, especially in this patient. And it's quite worthwhile doing it because these patients improve with diuretics, which you might be reluctant to give. And of course, it informs the management of RV afterload reduction with inhaled nitrate or prostacyclin or inotropes. So you want to talk about the renal vein Doppler as well. And again, renal Doppler vein is also same as the right-sided pressures increase. You start to get just instead of continuous renal vein flow, you start to get only a blip in systole and diastole, and then eventually there's only diastolic flow in a severe right-sided congestion. So I'll probably include that in my answer as well. And at the end, you want to talk briefly about what are the features of elevated left atrial pressures as well in your answer, because we mentioned initially that actually respiratory failure could also be cardiogenic. And what sort of, just to finish off, what are the features of the elevated left atrial pressure you will be talking about? Obviously, you will be talking about 2D features and mitral valve pathology, but also certain parameters. So what sort of parameters come to your mind when you talk about elevated LA pressures?
2D.
Sorry.
Sorry, go on.
No,
go
you
on.
go.
2D features of a dilated left atrium, and you can pick up left-sided pathologies. And there'll be Doppler features like E by A velocities, as in the E by A ratios will be increased. The E velocity per se will be increased, more than 1.2. E by E prime ratios will be more than 14. And then you can do a pulse Doppler assessment of the pulmonary veins, which will again show.
Before you, sorry to interrupt. Before you move on the from the E wave, the other thing while you are just there with your probe is look at the D cell time. Less than 160 milliseconds, so would suggest elevated left atrial pressure. And carry on.
Yeah, and then similar to the right-sided changes in the hepatic veins, there'll be changes in the pulmonary veins, which will essentially progress from systolic blunting to reversal.
Yeah, that's good. And sometimes you start to see the L wave. Have you guys seen L wave in the mitral inflow? So normally.
So normalization pattern and diastolic dysfunction, we see it commonly.
Correct. So normally it's E wave followed by A wave, isn't it? But when you start to get elevated left ventricular and diastolic pressure, you get this bump in between.
Yes. And suggestive of flow during the diastasis period.
Yeah. And this, I mean, especially if it is more than 20 centimeter per second sort of velocity, it's significant. But most of the time when I see L wave, it's the patient has diastolic dysfunction and likely elevated left-sided pressures. As I mentioned,
also the septum, interatrial septum will be bowed towards the right atrium.
Yeah.
Which it normally is, but then throughout systole and diastole, throughout all the phases.
Okay. Yeah, and of course you would measure the cardiac output just to make sure this the phenomenon of whether he's got septic cardiomyopathy or something like that, and the patient has got poor stroke volume, and this LFT derangement and renal dysfunction is a part of cardiogenic shock. So big answer. So this type of questions we would classify them as the breadth question in the exam. So you really have to touch a little bit on various aspects and not too much deep because there's lots to write, isn't it? So I thought I'll show some images from my talk that we did. I did a few months back. So these are the A lines, which you can see multiple horizontal lines just below the right pleural line. That's the reverberation artifact from the the ultrasound waves bouncing between the probe and the pleura. These are our B lines coming in, extending to the end of the sector, and these are the definition points. And more than or equal to 3 we are interested in. And of course, as they become more prominent and confluent, there's more extravascular lung water, and this is just to show the same how it progresses from just few B lines to just complete whiteout and then hepatization, and then you might see pleural effusion with that as well.
Shivesh, can I ask a question?
Yes.
So if you go back to that previous slide where you've shown the progression of B lines.
This one?
Yeah, this one. So between the third and the fourth picture where you've gone from white to gray. So what's happening? Because the lung is solidifying and all the interstitial edema is going away. Is that why the change from white to gray? Is that why it happens?
So look. Good point. Why does the B line occur? So B line occurs because there is septae which are filled with interalveolar septae, which is filled with edema, water, right?
Yeah.
So they work as a ping pong ball. These ultrasound waves comes and just bounces with those septae which are very close to each other, and they just keep bouncing very fast between each other, and there is a bit of a resonance, and that ring down effect happens. Eventually, what happens is that the fluid seeps out from the interstitium into the alveoli. That's the natural progression. So once you have got alveoli filled with exudate, then you obviously lose that bouncing around of the sound waves between the septae. Does that make sense?
Yeah. Thank you.
All right. Yeah. Okay, just to show the lung sliding here. Okay, this is what I was showing. On the left hand side, you've got a regular pleural line, and the right hand side you've got the irregular. So right hand side, I would be thinking this guy has got either viral pneumonitis or ARDS happening. Whereas left hand side, it could still be those in early phases, or it could be cardiac pulmonary edema. Is that a video? Yes. What's happening here? You can see the B lines coming in and out, and B lines are very helpful because it shows you the lung. So you can see that coming in, and this is what really you want to see. If there's no lung sliding, but then the lung point happens, the lung comes into the picture. This is that stratosphere sign or the barcode sign on the right-hand side with pneumothorax, where the horizontal lines just keep going. This is that lung pulse sign where suddenly the lungs come in during the M mode. That's the lung pulse. Can you see on the right-hand side with the M mode, there are pulsations that the interruptions in that normal horizontal linear lines, and that's cardiac pulsations coming in. All right. Yeah, nice one. That's the air bronchogram. It looks bright, obviously, because of the air. Not sure how well it is projecting, but I was trying to show air bronchogram, but dynamic. So you can see a bit of movement in those bright echogenicities, suggestive of consolidation. You can see a bit of pleural effusion as well. Yeah, again, a collapsed floating lung full of B lines. Yeah, fibrinous strands, as you can see, suggestive of complicated effusion. Hematocrit sign. I'm sure if you look up, you will always find a new sign, but it's all showing. I mean, this needs a bit of training of the eyes. It just you see this fine echogenicity floating around, and we have seen this in hemothorax. And the more you see, the better you get at guessing that there might be blood in there. Plankton sign. You can see those punctate dots floating around. Early exudative phase. Jellyfish sign. All fancy names, but meaning the same thing. Yeah, that's it, guys. Thank you. Any questions, or if any aspects you want to discuss?
Do you have any sorry, it's more of a general question. I mean, other than sort of doing past questions and practice during this teaching, any tips on how to prepare for like the written?
Yeah, look, the written, well, when you start doing those questions, you find that there's a certain structure that if you follow, you are able to answer all the questions. And I guess the structure is important. And because you might find that if you don't follow structure, there's a lot of repetition. You mention signs for one pathology, and then suddenly you find you're mentioning the same signs for other pathology. So I think you will get an idea of the structure. The more questions, I think for me at least, it was quite useful to do the previous questions. And after you do 20, 30 questions, you find out that actually there is only three or four different styles of writing the answer pretty much.
Sure.
And look, I'm not sure how many of you are from KICM pathways, but in KICM exams, we ask for critically evaluate questions. And this is something that might be coming in DDU exams as well, where we look at what's your opinion of lung sliding or use of lung sliding in assessing for pneumothorax. Well, then you go through what is the basic physics behind it, and then how it is useful and how it is not useful. And this is like very good for Doppler examinations of various valvular pathologies because they are full of limitations. There are some strengths, but a lot of limitations. And how do you go about those limitations? This is a structure that you might be using for those sort of questions. Clinical questions are also like this. Clinical questions pretty much similar. What do you think is going on with this patient? What are the differentials? How is echo going to be useful? Writing down the pathologies and what you're going to find for each of those.
Thanks very much. Thank you.
Potentially a dumb question. Where are the past exams? Where do they live? I haven't been able to find them.
Oh, just well, I've got some, and but the biggest collection is sitting with Sam, and Rohit. I'm not sure whether if you have some past questions as well.
I've got some physical copies that I took from Shivesh. I may have some online copies as well, soft copies. If I can, I'll forward them.
Just check with Sam as well, because Sam has got a big bang, because he used to give us exam practice questions as well. All right, thanks guys. I wish my whiteboard worked, because that was very useful. Anyway, I think we managed to cover all the aspects. Thank you. If you have any questions, feel free to flick an email if you want.
Thank you.
Thank you. That was very helpful. Thanks very much.
Thanks so much.
All right. Bye.